Wait for him, okay? We ready? Good morning. Let's go ahead and call the HR committee to order. We have no citizens wishing to address the committee, so our next item on the agenda is approval of the minutes. Are there any corrections to the minutes? All right. All right, it's been motion by Dr. Poshwich and second by DT. All those in favor signify by saying aye. All right. Well, our next on the agenda is Ms. Walker, Ms. Pia Walker on the policies. Okay. And I guess we have to do each one of these one at a time. All right.
Yes, so good morning. We have 3 policies to approve this morning. The first policy is HR 1100, competency test. Do we have approval to approve?
Oh, okay, I'm sorry. Someone to my left was bothering me. Can I get a hook? All right, all right.
Okay.
It's been moved.
Okay.
Oh, let me carry it through a minute, okay? It's been moved by Dr. Purwitt
Yes.
and second by Steve. All those in favor signify by saying aye. Aye. Those opposed by nay. Okay.
The second policy is HR 1200, performance management.
There has been nothing substantially
been no
changed on
changes.
these policies,
Yes.
okay? All right,
Okay.
all right, it's been moved in second. All those in favor signify by saying aye. All right,
And then the third policy is HR 2400, mandatory training.
are there any questions on that? All right. All right, we have a motion by Ralph and a second by Dr. Podovich, and all those in favor signify by saying aye. All right,
All right.
all right, thank
Okay.
you.
Thank you.
That's for now.
Thank you very much. Thank you for coming. We're here all week.
Bill, are we doing this now, or are we doing this in closed session?
Your pleasure. We'll do it no time.
Are we supposed to?
Yeah, this is
This
just
is
review
just-
of the metrics.
Just our metrics, okay, all right.
Yeah, this is good.
That has to be an open.
It's so, okay.
This is all good. Good morning, everyone. This is an opportunity for us to bring forward the performance of the organization relative to the metrics that were approved at this level last year and validated by the board. This is the annual incentive plan. We have 5 pillars that we have lifted up to the organization and established metrics for each of those. I think each of you have those in front of you, and I'll explain the color codes. This is a little bit unsettled, and I'll explain that because usually we have a meeting in December where all of our outcomes have been finalized. Quality will not be finalized until probably the latter part of December, but as you see the performance, the actual performance of fiscal year 18, it doesn't make a material difference to the annual incentive plan because we did not reach threshold for either one of those indicators. Those shaded in blue are all final. Those in the orange or pink are going to be finalized either the first week in December or the 30th of November. And you know this plan is predicated on a break-even financial operating margin. And our auditors are currently looking at the actual numbers for fiscal year 18 and will most likely not have a final opinion on that until the first week in December. All of our service metrics, indicators will be finalized the 30th of November. So I've attempted to give you kind of a variation of how that might go. But starting from the top, quality, the surgical site infections, we certainly started off really, really well last year, but did not accomplish what we set out to accomplish in that particular goal and pillar. Population health on improving days to next third new patient appointment. Can't tell you how proud I am of the team to really focus on that and knock that out of the park. We hit 11 of 14 primary care clinics are less than 25 days from the time a patient calls for an appointment to the time they're seen. We recognized there was a real concern from an access perspective for specialty care. We recommended that we focus on 4 disciplines last year. We worked really hard to clean that queue up. It was not a place where we wanted it to be. It was more than 100 days. And we ended up this year at 91.6. And it is still a challenge. It's still something that we need to focus on going forward and something that we need to bring down to a more reasonable level. But that is a final number for fiscal year 18. The service levels, which will be finalized the 30th of this month, HCAHPS could go either way. We don't know at this point in time if it's going to be a 71 percentile ranking or a 72 percentile ranking. But it will most likely be no more than 72nd percentile. The CG caps and ED caps, even though it won't be final, we feel very comfortable that we're going to end up at a 30 percentile ranking for CG caps, which reflects the overall rating of the primary care providers and the clinics. And we're going to end up at well beyond the stretch target for our ED caps, which is remarkable given the volume they see, given the number of patients that routinely are boarded on the walls. It's an incredible environment and an incredible team and an incredible leadership that has directed that effort. So I can't say more about that and applaud their efforts. The FTEs per adjusted occupied bed, or the productivity measure, Sharon's kind of told you where we were in October. It's a continuation of the success we had in fiscal year 18 as well. We ended up the year at 5.58 total paid per adjusted patient day, and that's beyond the stretch target that we established. Reduced cost per adjusted patient admission. This is a somewhat revised definition from where we began last year. And I can call Sharon up for more detailed explanation. She and Dorothy have had extensive discussion about this modification. This is excluding the IGT for the most part that we have no control over. And it was meant to establish just those costs that we could either influence or control. And if you eliminate that particular component of the definition, we ended up the year at 14,811, which is equivalent to a target expectation of 14,813. The net operating margin, as I referenced, is under review with the auditors, and there is certainty that we will not hit that 0.2% threshold level that we had established last year. We think we'll come in closer to that 0.1, but until the auditors have finished their work, we can't really say that for sure. So the people pillar and the high level of employee engagement performance outcomes that we established, we did really well. We were in the top decile last year. We ended up at the 91st percentile this year with an even higher participation rate from our employees, 93%. So 4.39 was our ultimate stretch performance level, but we came in at 4.37, which is phenomenal given the distance that we've come from over the past. So that is where we're going to end up the year. I don't see any real material changes in that, even though we're waiting on some final outcomes. I'll be happy to answer any questions anybody might have about the annual incentive plan for fiscal year 18.
Yes, Israel.
Bill, can you refresh my memory on the difference between target and stretch? Who determines the target?
Well, as we discussed last year and have discussed a lot, this is part science and part art, right? There's statistical significances, there's levels of difference from a standard deviation perspective, but when it comes down to it, it's constant improvement. In some cases, we're looking to equal benchmark where others have performed. In some cases, we're looking at improvement over self. But we're always trying to improve what we ended up the prior year. So in working with our consultant from Pearl Meyer, Steve Sullivan, whom you'll hear from momentarily, we really tried to focus on a threshold at a 90% probability of accomplishment, and a target at a 50% level of accomplishment, and a stretch at a 10% probability of accomplishment. That's kind of the art and kind of the science behind it. Does that answer your question? Okay.
Okay. Any other questions? Okay, thanks,
Okay.
Steve. Wait a minute, Steve, do you have a question? I see you.
Okay.
So on the ed caps, this is really intriguing to me that we just
It's-
like blew it out of the roof, right? How do we, first of all, can you kind of highlight maybe some of the components of that metric, just sort of what's measured that gives you that kind of score?
Well, the ED caps, we're changing that a little bit, but it's just like the H caps. There's a series of dimensions. And I don't know, Laura, you might want to come up, or Annika, and talk about the specific dimensions of that questionnaire. And it's kind of like CG caps. We're looking at time to arrival to be seen. We're looking at the responsiveness of the ED physician to see that patient. We're looking at the time they spent dwelling in the ED. If they were boarded in the ED, that's probably going to end up being a survey that is sent to them from an HCAP perspective, because if they're boarded, that means they're going to be admitted.
Right.
So even though their experience in the ED is going to impact their overall perception, it'll actually be measured from an HCAPS perspective. But the ED is a sampling size of questionnaires sent, and we do some telephone questionnaires too for those who have been seen in the ED. You want to go over the specific?
So Annika is here as well, and I'd like to introduce you to the group, if I may. Annika Fisher is our Executive Director of Patient Experience and Strategy, and has been with JPS now 2.5 years, and just does a phenomenal job. She can speak to a lot more of the specifics of the surveying methodology, but the survey itself actually captures those in our emergency department that is in the main ED, and then it also captures our clinical decision unit, which is where we send patients for observation before they're either admitted to the inpatient floor or discharged home. Sorry, no, I thought it was on, Scott.
Okay,
Sorry.
can you start again?
Sure. So, and then Annika, if you'll speak to the dimensions and methodology, I think a little bit, that would help.
That'd be great.
I believe
Yeah,
answer
thank you.
some
Just-
questions.
Just
so.
briefly, you don't have to.
Okay, so as far as ED caps goes, it has a very similar dimension base as the inpatient setting. So we're looking at our provider communication, our nurse communication, how we hand off patients, et cetera. So it has a very similar methodology, but this specific question for fiscal year 18 focused on just overall rating. So this really looked at our percentage of patients that gave us a 9 or a 10 experience level. And as Mr. Whitman mentioned, it is a random sample of discharged patients from our observation unit or from our ED. So, we started a little bit on the lower side of things, and we tried to set a realistic goal, and it was just an incredible year, a lot of effort going in from our clinical decision unit team as well as our ED team on how do we streamline efforts, efficiencies, improve communication from the provider piece as well as our clinical piece as well.
Great. Well, I commend everyone involved with getting that. That's fantastic. Congratulations. Now I'm real interested in how we set as our benchmark for next time. I mean, we knocked it out of the park.
For fiscal year 19?
Correct.
Yeah, so that actually is not part of what Mr. Whitman will go over in just a moment as far as our AIP goals, but it's certainly something that we will continue to track and work with the ED, and I'm happy to bring that and report it to the quality board this year, and so that we can continue to watch the momentum.
Fantastic. Well,
One of
thank
the
you,
things
Bob.
we are
Yes.
switching in the ED, so last year we utilized the ED CAP survey, which is that official survey. But as that has kind of been put on the back burner from CMS, we're really looking at a real-time survey for our ED as well. So we've transitioned them over to that survey. So we have two running simultaneously right now to get really good baselines.
Sure.
So that's really our goal for next year. We've seen in areas where we've implemented that real-time survey, we see almost a tenfold in returns.
Well, you can be more responsive, right? I mean,
Absolutely.
Yes.
It's next day, there's an opportunity for service recovery very quickly, rather than a 30-day time lag between the time they get it and receive it. And the phone survey is actually anywhere between 45 seconds to 2 minutes, versus this one is over a 12 to 15-minute survey. So it's much more patient-centered.
Yeah.
And allows us that ability to service recover quickly. So that's really where we're going to focus in fiscal year 19, is capturing that real-time data in our ED settings, clinical decision unit, as well as our urgent care center. So that'll be our main focus. We'll still keep a minimum of ED CAP surveys available should CMS ever decide to go back. We'll have that statistically significant number, but we really feel that to be more patient-centric, we want to have that real-time survey available.
Right on. Thank you. That's great. Thank you very much.
Let me also, Madam Chair, if you will, remind you as board members, and I know that you all know this, particularly Pastor Emerson and Steve, that the ED was our pressure point of real challenges when we really started this big initiative at JPS 10 years ago. It was a really tough spot for us. And also for those watching live streaming and maybe unfamiliar, from the time that this administration took the realm, we had 147 people daily census. We're at 380 daily census in our emergency room over that time period. So to have those kind of numbers speaks to the type of physicians we have. It speaks to the type of nurses we have, technicians we have, and everybody else we have down in the ED. That it truly, not to overplay the term a village, but that truly is the comment of the village, and part of that village is you all. And what Bill described earlier and what Dorothy's worked hard at is trying to come up with realistic goals. But if you set goals that are too unobtainable, it's almost like a diet. If somebody says you've got to lose 150 pounds in the next 2 months, you're probably going to continue to eat chocolate bars and ice cream. If somebody puts a realistic level to that and you see improvement and change, you're much more likely to hit your goal. So you got to hit that sweet spot of getting tough enough, but yet realistic enough to hit it, because if it's unrealistic, you won't. And what they've done in the ED is pushed it really hard, but they've been a great team, and that is a tribute to y'all and this organization in its totality, because that really was our most pressure point when this administration first started.
And one of the other things, Steve, they did is start comparing it to other trauma hospitals. That was making sure that we were in the right group to look at when you were just looking at everything and we were trauma. So they kind of did some things to make sure we were comparing apples to apples. Okay. Any other question? I saw your hand up.
I was going to ask, but I'm not sure it's appropriate for this one, because I'm more concerned, not concerned, but, you know, sometimes you can do well, but perception may not. And there may be some item that we may disqualify from looking at it to keep it standardized. But do we have a kind of a shadow survey for families that have disease that probably will not be part of this admission to ED?
If a family member has been, if a patient had been deceased at time of discharge, they are ineligible to receive a
That's what I
survey.
meant. So is there a shadow one so that we can keep track of the perception outside? Because that and also left without being seen would not be part, it technically should not be part of this study, but somehow we should have a shadow survey tracking to make sure that a public image is in sync with what we do on the clinical side. But it's probably not appropriate for this one, so I'll table that one, but
For
we
any
may
of the
wanna talk
CAP
about it.
surveys, so for any of those that have that CAPS methodology at the end, so HCAPS, our CG CAPS, urgent care CAPS, any CAP survey, we follow CMS methodology, which excludes a lot of those variables. If a patient's under 18, deceased at time of discharge, certain diagnoses codes as a primary code get
disqualified, but that's equivalent to every other.
Right. No, I
Organization.
understand that part, but I just wanted to make sure that we
Okay.
don't forget that it's human to look at the whole
Absolutely.
holistic view, so just, but,
Great point.
but we should follow the standard. I'm not,
Agreed.
yeah.
Yeah, I agree. Thank you.
Any other questions? Thank you.
Okay, thank you.
All right.
So behind that is our proposed annual incentive plan metrics for fiscal year 2019. We focused on surgical site infections specifically during the year fiscal year 18. We want to move to a more global composite safety ranking, and there is one that enables us to compare to other organizations nationwide. It's called PSI 90. It includes 10 different safety indicators. So we're suggesting that we focus on that this year as our overall hospital safety index. One is right at the 50th percentile. As you can see, we ended up the year at 1.1, which is a little bit higher than we want it to be. Anything below a 1 is considered better than the median. So we want to establish a threshold of 1.21 as our target, which equals the national comparative benchmark, and a 0.88 for that particular metric. And that is differentiated by one standard deviation between the threshold and the target and the stretch. So that is statistically significant.
On us deciding on that, it was, on this one from last year, you just had two quality matrix that we were looking at. This allows you to look at least 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's a broader spectrum, which I believe will help us improve quality. Okay.
And it's a focus on rates versus a focus on individual encounters or clinical issues. And given the acuity of those that we treat, rates is probably a much better indicator of incidence. Service. We talked about those three metrics, the three indicators that we followed this year, HCAHPS, CGCAHPS, and EDCAHPS. We're suggesting that next year we focus on the dimensions, not just the overall rating of the inpatient experience, not just the overall rating of the primary care provider, but focus on the number of dimensions of improvement that are in these surveys. We know from our vendor, NRC Picker, that there is a national rate of improvement for each dimension, and it varies by dimension. One could be a 0.1, one could be a 0.5. Whatever that national rate of improvement is, we would suggest that we would hold ourselves to an improvement of 3 of those dimensions at that national rate to equal threshold. An improvement in 5 of those dimensions at that national rate of improvement per dimension would be target, and 8 would give us stretch. And that is continual improvement over where we ended up the year, fiscal year 18. CGCAHPS is something, as you heard Annika talk about, the time requirement for the EDCAHPS. It's onerous as well. It takes a lot of time to complete the CGCAHPS survey, and organizations are getting away from CGCAHPS. And we're going to propose a series of questions that are nationally ranked, so to speak, although we don't have a lot of experience with it. But we want to focus on questions that are meaningful to our patients in the clinics and improve 3 of those questions from where we ended up fiscal year 18. Improve 5 of those for target, improve on 8 of those for stretch. We want to establish our own internal rate of improvement as 0.3. So every one of those questions, we would have to equal a 0.3 improvement or better to qualify for any question that improves over last year. So if it's a 0.1, it's a 0.2, doesn't count. It's kind of status quo. You've got to be 0.3 or better to to register improvement for each of those questions. People, we have the opportunity to focus on some things that we feel are not in keeping with where we want to be. Turnover is one of those. Turnover is very expensive. Although it's not runaway turnover, you can see that, well, I'll explain it. 11.2 is our national benchmark. We use a national benchmark called Saratoga, and most of the hospitals, all the hospitals that we compare ourselves to, and it's a very large database, 11.2% is the median. We ended up the year at 13.06. Still higher than we'd like to be. We want to achieve 11.2 or better. So we proposed that we have a level of improvement of 12.7, and this is something that our folks have helped us with to establish these performance levels. 12.7 threshold, 12% target, and 11.2%, which is the national benchmark, would be stretch. We have had great success in focusing on our people engagement. We want to continue to do that, but given the year ahead of us, that it's going to be a challenging year, we know that. We have suggested that we have a little bit of room from a threshold perspective. This is the 80th percentile, is 4.27 currently. 85th percentile would be equivalent to around 4.32, and the 90th percentile, top decile, would remain at 4.36. That's what our vendors have told us in the past, is that once you achieve these higher levels of performance, you can expect a little bit of regression. And as you all know, it's going to be more difficult to improve upon something that's already pretty significant in the first place. We also want to focus on provider engagement. That is something that we really are in tune with, want to understand the opportunities that we have. We recently completed a provider engagement survey. The results of that are 3.89. And we've established with our vendor levels of improvement for next year at 3.98, 4, and 4.02 for stretch. Under stewardship, we
Bill,
still want to focus.
Before you go farther, can I ask you?
Sure.
I want to ask before I forget my question.
Okay.
Age will do that to you, okay. Let me go up to HCAPS for a second. The threshold is 3, the target is 5. So we looked this year at those reasons, those reasons or outcomes that we didn't maybe reach some particular areas. We didn't get to where we want on the target. I'm assuming the staff discussed that.
This year, it was a focus on percentile ranking.
Okay.
Right.
So there's a plan being developed, a plan in place to get to
Yes,
where?
sir. Yes, sir.
That's
Every one of these requires an action plan. There's
Okay,
no
that's-
question about it. It's not happenstance.
All right.
There's got to be a plan.
Okay, yeah. Then let me go to because I can ask this to Robert and to Pia also. The Dallas Cowboys luckily won last Sunday. You can tell I'm not a Cowboy fan.
I agree with the adjective.
But they were sky high. And if they're not careful, they'll fall flat on their face this week when they play Atlanta. So when we look at JPS and we're at this high percentile of performance and turnover, it is because we are providing a great work environment and benefits. But based on budget and what the tax rate is, we may not be able to do that in the coming year. So what are those things we will be able to put on the table or provide to keep that motivation there to keep me here at the hospital, that there's not a turnover. If somebody's making the pie sweeter across the street, I guess that's just what my concern is.
Ours as well, and it's going to be a challenging year. And I don't have those action plan specifics for you, but I think it's a rededication to what brought us to where we are today. We can't be complacent. We've got to continue to focus on the engagement piece, because without our people engaged, they're not going to provide the care that we expect them to, right?
Okay,
And
so,
we have to maintain that focus on our people.
so that means that,
Maybe,
so that means that Robert has to provide more pancake breakfasts, or?
whatever it takes.
You betcha. You betcha, that's exactly.
But I just.
If that's it, that's
Yeah,
it.
Yeah, that just concerns me that we're riding a high, and I'm just afraid that they expect another high. What is that?
Well,
you
and
know?
that's the rationale behind the recommendation on employee engagement percentile ranking, is that at some point, you reach diminishing returns, and the more you do, the less impact it has, and you just have to be more vigilant, you have to be more creative. And this requires more work. Even at the 80th percentile, it's going to require more work for us
Right.
as an organization. Turnover, you're right. If we're not competitive, we're going to lose people. We don't want to lose people. We built this organization a long time. We're not going to turn our back on the people that make this organization what it is today. This is going to be a tough year. It
But-
truly is.
But we also, Ralph, made sure that when Sharon was doing the budget, that we looked at the employees and made sure that we had a market adjustment in there so that we wouldn't fall behind in those critical areas that the employees said that is important. So that's one of the deals that as a board, we have to make sure that that's included, and that was included. And we'll just take it from Steve. He'll give us the rest of the money.
Montgomery.
Yeah, but that is a good portion.
And another challenge that we have is to effectively communicate and cascade all of these goals and indicators and levels of performance throughout the organization, because not one person can do it, not one division can do it, not two divisions. It's got to be an organizational effort. So not everyone understands their role in a quality perspective and a service perspective. It's our job to find a way to message that it is theirs, and here's how you can play. So I was talking about provider engagement before I moved to stewardship. That's awfully important to us as well. Just as employee engagement is important to the organization, a focus on the providers, how we can support them, how they can support us. It's a two-way street. Stewardship, as last year, this is kind of a bifurcated metric. For VPs and above, we're focusing on operating margin. The thought being leadership can have more of an impact from an overall margin perspective, can influence or control revenue as well as expense. Below the VP level, it's more difficult to have an influence or control over revenue. So we're suggesting that the frontline folks focus on a modified cost per adjusted admission, and this is net of any physician remuneration compensation. So we're taking everything out that they can't influence directly or control and allowing them to focus only on those things that work in their realm of in their environment. So the operating margin is, I believe, 0.25 is budget. Sharon, is that right? 0.25% is our fiscal year 19 budget, and a $3 million improvement over that budget would be target at 0.66, and a $5 million improvement over that threshold level would be 1.2%.
You see my challenge, Pastor? I can't buy more pancake batter and keep that budget working and yet keep employees happy.
Right,
So it's going to be a tough challenge.
right.
Bill, may I ask a question? Am I looking at the number correctly? the 12,799, should that be 14,811? That's the projected number from the last screen?
That is based on the new definition,
Okay, with the
the
adjusted
new
out, okay.
definition. So it's apples and apples. If you might recall, the previous slide reflected a performance of 14,811.
Right,
That was another definition. So this is a proposed definition for your
Will we adjust
consideration in
those out?
fiscal year 19.
okay.
So the main difference between what you saw on the slide before and this one is simply the physician costs that were removed.
Got it.
Make sense?
Yeah, because I didn't
Okay.
see the number add up, that's why.
Population health, as we discussed in the previous fiscal year 18 AIP, specialty care access is really, really important to this organization. It's important to our patients. If we don't focus on that, those folks are going to end up in the ED. That's just going to continue to clog the system in the ED. So we've got a challenge. We're focused on 4 disciplines, 4 service levels. We're focused on GI, pulmonology, urology, and blanking on the 4th one.
I have it.
Somebody help me from the back.
Hold on, I got it somewhere.
Urology, GI,
Neurology. GI, neurology,
the ology. These were 4 disciplines that had the greatest impact on our Medicare population. And we saw that their average time to get an appointment was over 100 days last year. That's too long. If you want to call for an appointment in one of those disciplines, you're not going to be happy with 100 days. So you're going to go to the ED for the most part if you have an acute condition. So we've whittled that down, as you saw in the previous slide, to 91 days. That's still not where we want to be. We've got multiple challenges in getting that queue down to a level that is reasonable and expected. So this is continual improvement, right? This is improvement over the self for the most part. And this, I believe, reflects a 2% and a 4% improvement over current levels of performance.
I'm just going to say it out, or come out from it and say that even if reducing it down from 100 to 91, that's still 3 months. And so when I look at this and say your target is to reduce it now for 1.8 days, I cannot go along with that. That is not an appreciative improvement, because that means the patients are waiting 2 months and 28 days. So on this system, I know we need to focus on it, but I don't think that on your annual plan, unless, now, Sherry, Dr. Duncan, you probably need to come on up, because if we have the doctors, then there wouldn't be a problem for us to reduce this. We have the space, if I'm not mistaken, but until we have some providers or a contract or something so that the patient can be seen, this measurement to me is one that I'm not comfortable with leaving it on here. I'll just say that, because it's not fair for me to say, okay, let's decrease it 10 days, when you know that if you don't have any doctors, space is not the problem. Am I correct on that? Your doctors would, if we had doctors, they would have spaces that they could see patients.
That is correct, that there is opportunity within some of our sites outside of JPS and some
Right.
of our clinics,
Okay.
that we could place some providers.
Okay. So you've done the processes, reduced the referrals, worked with the doctors on seeing the patients. I just think that unless there is, I think you can continue to focus on it, but I don't think it need to be on the annual plan if there isn't any way that we can go more than 2 days or 4 days. Now,
Have we looked at potentially having a higher,
Put the mic closer to
you
you.
know, sometimes patients, when they have UTI and all that stuff, they end up in the ED, but is there a way that we can intervene while they're at home to telehealth or something like that, to reduce that, to open up some of the you know, because I saw some health systems start looking at from that perspective.
So DT, can you ask that again? I'm sorry.
I'm not sure if a lot of time when patient goes to the ED, it's because they don't know, because of the infection and all that stuff, UTI and all that stuff. Is there a way that we can start injecting to intervene while they're at home, so that we don't walk up the ED room to make room for other stuff that we are doing? I don't think we can ever, just changing things around a little bit more.
Yeah, so,
in terms
yeah, you know, Dorothy, I guess I'm a little bit quiet here because I think it's multifaceted. And DT, I think your question is a good one, but maybe a little bit different because we have a lot of work that's going on with our district and moving a lot of that unnecessary high-cost care from our ED and our urgent care to our primary care. And we are working with the doctors in having direct scheduling now in the ED, in which they can schedule that patient that they see does not have a primary care home or needs follow-up in the primary care home. So we are doing a lot in re-educating our patients as to where the best place of care is. Dorothy, I agree with you. I mean, we would like to be able to give our patients an appointment before they leave. And I think that's, if you were to ask me, I mean, I think our target would be that it would be less than 30 days. There's a lot of factors that go into play, from the scheduling to the pre-authorization to actually putting them on the schedule, and then having, as you said, having the supply of providers, depending on the specialty, the supply of providers to see those patients. I do like having it there because I do, the optics of that, as long as it's out in front of the board, forces us to come up and work together in being able to get to that target.
Is this because we don't have enough specialists, or is it because of over technology that we got bogged down and not and kind of lose
I think
track
it
of the
depends on
patient?
what specialty you're looking at. I think it's, you know, we know across the nation that we have a shortage of specialists, and that we will continue to compete in order to get that. I know Acclaim is working to, you know, look at whether we can outsource some of this, whether it makes sense to bring it internally. So I think it really depends on the specialty. And I mean, we're going to have increased demand, and we're always going to be on the supply end trying to catch up with that. And so we have to get creative as how we begin to meet that demand.
Because I've seen quite a few systems that they offset that by monitoring the activity, because sometimes over technology can be bogged down and it doesn't rise to the level because of the way that humans set it up, rather than we can talk it offline, but that may decrease the
And we are working to decrease the funnel to make sure that our primary care providers are working with our specialists to understand what is a good referral, what is that can be managed outside of the specialists, and helping our primary care providers be better at actually managing a lot of what gets referred. So there, as I said, it's multifaceted. There's a lot of work and that has to be done around this. I see that we've done a lot of the low-hanging fruit over the past year, and as you can see, we've only been able to bring it down about 10 days, so that there's going to be a heavier lift for next year.
I'm back to my question, my problem is that if I listen to what everyone is saying, there should be a 10% probability, 50, 90, 50, and 10. And I'm saying, when I look at that, I am not comfortable with us having a measurement that we have less than 2 days on one and less than 4 days on a stretch. Unless we can do better than that, and definitely I want it to improve. And if you wanted to stay on here, then it's got to be more. That's all I'm saying. Because you can't, to me, it's not okay to say, okay, our probability is we can do it for, improve it by 2 days. That 2 days is unacceptable. So here's what I would suggest, is that that's a major focus that Acclaim and all of us need to really come up with a plan and say, here's what we're gonna do. I know they're recruiting. I don't know how long it's gonna take them to recruit. And our patients will continue to wait to see those specialists or come back to the ER. So it's kind of like a revolving deal until we actually address it, really put in something in place that you can see.
So is your suggestion to remove it from
Yes.
here? Because even if
Yes.
it's obtainable, it's not the desired effect of that. And then put an emphasis not only from the board, but from the staff, and report back to a variety of the committees, not only this one, but quality and others. And I think that the staff can accept that. I don't want to put in a goal that we busted to make and it's dissatisfier. And at the same time, I appreciate your attitude saying we have some challenges, and if we put an emphasis on that, we can work on that. It's not letting it go, it's
Correct.
putting a plan in place that's probably more encompassing than just a day feature.
Correct, that is what I'm saying.
And staff-wise, I think that is something that we can deal with, so I don't think you're gonna get resistance from us.
Right.
Still measure it, but if you're gonna accomplish this, it may not
Right.
accomplish
May
what
not
we
be the
need
best
to.
metric,
We put a
yes.
plan into place, we may get to where we're going better without the emphasis of the metric aspect.
For an institutional goal, we focused on 4 specialties that we know that we have difficulty getting to. So what we're doing is we're essentially neglecting what the ER is doing, neglecting what psychiatry is doing, neglecting what other parts of our system are doing, caught up on those 4 that we think we can probably, at a stretch goal, reduce it by 3 days. And so I don't have any power over that,
Right,
but yet I'm being measured.
right, good
And
point.
Dorothy, I agree. I mean, for me, it'd be, if it's to say, we really want to focus on this, then let's do a real number here. Let's do threshold at 70, let's do target at 60, and let's do stretch at 45.
30.
And then that way, everyone says, how do we get the resources together? How do we make that happen? But I know we can't do that because
Right.
it would never be attained.
Sure.
Can't do it
I think
overnight.
finding something that the system in terms of population health can do. Hemoglobin A1C changes over
Right.
the next year. I mean, reducing the amount of diabetes is something that, guess what? I can do.
And we've done some great work, and I have to say, we've concentrated on these 4, but if you look at some of our other specialties, we're bringing them down less than 30 days. But these were the ones that we had the most challenging with, but it has downstream really been very positive in our ability in many of our other specialties to get those patients in less than 30 days, so great work that I think
It
we
would
can
seem to
continue.
me that if you did that and you looked at it in its overall context, not just the 4, but everybody, we reported that out as well, and we looked at reducing those numbers, and we kept it in a plan in front of the board. You've got wins for our patients, you got obtainable approaches by the administration, and I'm happy to see some of our doctors in the audience, that buy-in from our doctors, from Dr. Fowler, who chairs family medicine, and others. It's important, and I'm appreciative that you're here because it's an all-encompassing kind of deal. And what we've learned in the last 5 years, if administration is just standing at the street corner screaming and yelling, it doesn't happen. It's got to happen with your input to your colleagues, Dr. Fowler's input as a chair, and others, that makes it happen. When it's that collective effort, here's the directive we got from the board, here's where we want to go, as opposed to Karen Duncan, Bill Whitman, and Robert Early screaming until they're blue in the face. It doesn't get you where you want to go. Or Tricia Swift.
I agree with you. We shouldn't put things that's not attainable, but we check on the back end. There are other substitution for population health if you want to go down to like looking at GPRO reporting or HEDIS reporting, see how we improve, or look at the HCC score to see how sick our population is and how do we look at, physician practice variance and all that stuff, or referral pattern or network leakage and all that stuff. That more like controlling the population where they flow first, right? You have to build the building step, and then we tighten up more and more every year. But at least we have the foundation as we switch over to value-based and all that stuff, or share savings or whatever you guys want to do. But that's, I think, more
No,
attainable.
I agree. I think as we mature to more value-based conversation, I think that will become much clearer as to what those correct metrics should be for population health. Totally agree with you, DT.
Like to, you had something you wanted to say, Ralph?
No, I was just to say, if I understand, then it would be on the scorecard, but it would not be at the point of affecting the overall score of the scorecard.
It would not be on this incentive plan. We would take it off. That would be a focus that we would be doing. That, and I think quality is one of the areas that we ought to be following it and making. This is a big system issue. Dr. Duncan can't do that alone, Bill nor you. It's got to be a system approach. So what I was suggesting is that we remove this part of the population health off of it now. We'll develop something for within the coming year for it. But I was thinking that we would just take the population health off and plop those 15% up in service, because it affects all of the providers and all of the staff. And half of the things that we're talking about will be picked up, some of it will be picked up there. And that we would reduce it from 5 to 4 for the coming year, okay?
Yes, ma'am.
May I ask another question on the net operating margin? Do you think that's attainable, or is it too stretched?
Sharon, the comment was the net, did you hear that?
Here's what I'm seeing. Right? I think this one was done prior to the bond. We may have some distraction.
in relation to the budget.
We may have some additional expenses that may hit your bottom line. I don't want people to be penalized by it, because, work around things as we move, physical location or accommodation for expansion and all that stuff, unless you can carve that out. Otherwise, we're going to be penalizing you guys for something that you haven't built that cost in, that kind of unknown at this point. May not be fair.
So from my perspective, the .66 is budget, so that's our target. The threshold is midway between our trigger and the target. Kind of the same philosophy that we used last year. And then the stretch is to say we're going to effectively double our budgeted margin. Yes, that's a stretch. But based on the 10% achievement probability, we may or may not get there. There are going to be a lot of challenges. There's going to be, because of the bond issue or the bond election, there will be additional expenses that we did not necessarily budget in preparation for a future bond issue, which likely won't happen during 2019 from my perspective, but we will be moving towards that. So, if the committee wants to reevaluate that 1.2% stretch, from my standpoint, that's the one number in there that we could look at and reevaluate, but the .66 is our budget. So,
Is there a possibility you can put a different cost center for anything related? Because construction, we can book differently because it's part of the bond.
Correct.
But the workaround plan, the temporary
The master
places and all that
facility
stuff.
plan and
IT
some
that
of
you
the
can't-
legal expenses.
Those are very expensive workaround that you have to accommodate when you do, you have physical move and patient flow and all that stuff.
So currently, we already do capture some of those legal expenses as we're moving forward in a separate cost center, because those now can't be capitalized as part of the bond issuance cost, but due to a change in accounting principles. But, you know, we can capture it. Again, you know, the 1.2% is more the art than the science. So,
For me, I would propose and Dorothy may not let me hear this, I would propose somewhere about 8.5, 0.85.
0.85.
Instead of 1.2, because it's
Okay.
a lot of work and a lot of time consuming for all you guys, and you get penalized at the end. But that's just my suggestion.
Appreciate
I just
that.
don't see how you're gonna move to 1.2. As even stretch or whatever that is.
So you're suggesting that they reduce the stretch?
Yeah, to about 8 or 9, that's hard to achieve, but still potentially gonna be attainable, but you put something way out there that nobody knows, they're gonna give up.
You know, I have no problem with that is not one that they've had me arguing with them on.
We
That
have
I
not
have let
discussed
the
this.
chief financial officer say that. I have not argued
Sure.
with her on that one.
For the record.
One that I was not expecting a lot of conversation on today, but I do appreciate your
Because we're gonna ask people to
insight.
do a lot more,
Yeah,
and then for something unattainable, it's
So
gonna
maybe-
be,
and I agree with what you're saying.
it's incentive instead of
Maybe a
incentive.
0.9 or 1% kind of margin, or something that isn't attainable.
Right. Because I see costs, the first year is gonna be a
Yeah.
lot, high.
Do we expect that cost to start in 19 or the next year?
It's already started in
Already
18.
started. You know,
Some of
is
the
the,
legal
we talked a
expenses.
little bit about having a, kind of like a contingency for finance. It's kind of like when we build something, we put a contingency in, and that's what you're saying on the budget. So I don't have any problems with you reducing that. That has been something that overall, Sharon has been directing that. Our discussion has been on what to take out of the modified cost of those things, but I haven't really, I'm okay with that.
If the chairman doesn't have a problem, I think we seize this opportunity.
I want to
I
undermine
heard a
the,
0.85, I heard a 0.9.
yeah, and I don't want to undermine the logic that got us to the 1.2, though. What was the thinking behind
I
that?
think it's
5 million.
It was actually just a doubling of the
Of the-
0.6%.
So not much more logic than what we just went through here.
Said that was more the art side. The logic side, I think, holds more true from the threshold is, okay, we're
Yeah.
gonna split. The trigger is the break even, so halfway between the 0.6 and the
Right.
break even is where we ended up.
So what do, Mr. Chairman and DT, what number would you all feel comfortable with?
I'm short, so I'll go with 8.5. Steve's taller, so he may set a higher standard.
So I'll go with 1, so when we compromise on 0.9.
It's
So you
tough.
want one? Okay. You know, I'm going once, going twice,
The liberal one on the board goes for the higher number, the conservative one goes for the tougher
From Sharon
number.
Clark, more is better.
well.
That's an
it's
oxymoron, I think.
What you can come back with is a, you want to think about it and really make a recommendation between those. I mean, they're okay. We're okay with you lowering it.
Yeah, I just would ask that all of us would remember or put some notes someplace in our memory bank so that when we're back here this next year, that we're not now throwing darts at staff because we didn't reach a particular spot when we agreed to lower it, or whatever that is. So I just want to make sure we have a tendency to forget about what we decided, and then we want to know why staff didn't achieve or accomplish.
You bet. And I think what would help you all a lot, and what I have noticed about this process is it's almost like when you write a paper and you kind of keep editing it. I would highly recommend that we choose a number We can live with it. You all have given us great input. Dorothy's given us a bit of a yield sign on that one, which we appreciate. I would much rather come up with the number here, because when you open up this box, and there's a lot of work that went into the paperwork y'all see today. Again, it's where Dorothy and Bill become really, really close. And both of them are looking for a vacation. So if we can come up with a number now, I would be delighted.
For me, 0.6 is
Oh,
already a stretch.
I can make a proposal,
0.6.
and then we can vote on the proposal
6 ain't changed.
to approve. So I'd like to propose that we approve this plan in that we take off the population health pillar, number
Yes.
one.
Of one,
There you go.
okay.
Number two, under the stewardship, the net operating margin, that the stretch goal become 0.9.
0.1, I'm sorry.
0.9.
0.9.
I'm more comfortable with 0.85.
Okay.
This, for me, 0.66 is already a stretch. And you have new
You
leadership coming
you
in.
can't compromise to 8.5?
So is there a second and then discussion, and then they can,
Yeah.
Okay, all right, and now
Second the
discussion.
motion, and now the discussion is whether it's 8.5 or 9.
9.
0.85, I
0.85.
understand. I understand. 0.85 and 0.9. Right. Okay, great. So now we
I
amend
will-
your motion.
I will amend my motion for the net operating margin to stretch be 0.85.
Thank you.
Okay,
Yes.
all right, I'm not gonna go through that again.
Madam Chair, the only thing you need to be sure on the population health 15%, that's moving up to service.
That's moving to service.
And then be sure that's part of the motion. So that'd be 35% instead of 20.
Okay.
Yeah.
You okay with that?
Yes.
Okay. All right, it's been motioned and second. All those in favor of that signify by saying aye. Aye. All those opposed by nay. All right.
Phenomenal work. It took you guys 6 months to get to that point. Look what they just did.
Yep, I know.
That stayed, that stayed, all these stayed the same.
Okay.
Stayed the
I got
same,
you.
the only thing that changed is here.
I got you.
Okay. Well, now that you done started trouble, yeah. I think that's, Bill, did you have one more, oh, wait, one more thing?
Yes,
Before you leave, we got one more item
Yeah,
that we got to
won't
go
spend whole
over.
time.
Okay,
I'm not gonna say that.
and then you can go, okay?
Okay, the next information I'd like to bring before the committee is the long-term incentive plan. And this is a 3-year plan, as you might recall. This is the 3rd year of that plan. Began in fiscal year 16, 17, and 18 was the 3rd year. It's the average performance of those 3 years. We had 2 different metrics the first 2 years. We brought a recommendation to you last year that more meaningful metrics were available to us, and that was leapfrog, because we really wanted to make an impact in the level of performance for this organization. And given the financial challenges that we now have before us, we anticipated that last year, we wanted to focus on cost. So 16 and 17, those performances are in the book. We know what those were. I think page 13, it's numbered on mine, I hope it's numbered on yours, is where we ended up fiscal year 18 from a leapfrog perspective and from an overall cost per patient adjusted admission. So we were a B again in the October report from Leapfrog. We came in at 2.9724. And we're recommending levels next year, which I'll get to. The cost efficiency is the same metric that was in the AIP, although the leadership did not participate in that particular metric for the AIP. That was for frontline only. This is the leadership metric for the long-term incentive plan. So both of those ended up the year at the target level. The recommendation for fiscal year 19 is to maintain those same metrics, leapfrog, and an adjustment to the cost per patient admission. Leapfrog, we want to continue to improve, and it's somewhat improvement over self. But you can see that We ended up the year at 2.9724. We want to establish that as our threshold, which is equivalent to a B minus. We want to move to a target of 3.0144 and a stretch of 3.0565. And this is based on more science than it is art. There are 28 indicators in leapfrog. 20 of those are already in the book, so to speak. It's a 2-year lag on many of those. Our performance has already been recorded. There's just not a lot that we could do over the next year to make that an A, to improve beyond the 3.0565. If everything is perfect and goes well, the best we could hope for is 3.0565 next year. Now, as you might recall, leapfrog is a destination metric of this organization as well. Our ultimate goal is an A, and I think we've got a 2020 target of an A. This moves us along that continuum to enable us to achieve that letter grade in 2020. And the cost per adjusted patient admission is equivalent to what we just discussed on the annual incentive plan for fiscal year 19. That's our proposal.
Any questions? All right, it's been motion and second. All those in favor signify by saying aye. Those opposed by nay.
Okay.
Thank you. Okay,
Thank you, ma'am. Appreciate it.
all right. We can't go into close yet. We got human. Yeah, we do have something for close. I'll get it. It can wait. It can't be that important. Okay, yeah, coming up here. If you need to go, it's okay. I don't think we have anything else I need to vote on. Okay. Thanks, so. Okay, all right.
All right. So next, what I would like to do is present to you the Human Resources dashboard. Of course, for us, what we wanted to do is provide an update for the close of the fiscal year, and also, too, looking at what we ended with our benchmarking scores, too, as well. So looking at the very top right-hand corner, for fiscal year 17, we did end with 287 vacancies. And with the year end, we ended at 275 for quarter 4 for FY18. Of course, as Bill stated earlier, with our AIP goals, one of our primary focus is involuntary turnover. And then looking at the numbers here, it's voluntary turnover. It's looking at the numbers here for the quarter. We ended at 12.20, and with Saratoga benchmarks, their recommendation is 11.2. So when you look at the very bottom of the dashboard as well, the key metrics to look at this is looking at that voluntary turnover. The data at the very end is annualized data. Looking at that annualized data, we ended the year at 13.06. So are there any questions relating to turnover? Okay. So next, let's move on to employee engagement survey. These are the results for our fiscal year 2018 employee engagement survey. The survey took place September 10th through September 21st. When we were looking at this data, as we have communicated, this has been a lot of work for the organization. We have been taking the Press-Ganey survey since 2013. When we're looking at this information and what builds the Press-Ganey voice model is the organization domain, the manager domain, as well as the employee domain. Key factors that we like to look at to ensure that we have a workforce that wants to continue to action plan and provide us with feedback is the Action Planning Readiness Score. When we look at those domains, what occurs is that it makes up the APR as well as the tier scoring, then what makes up the workforce engagement score, which then determines what our percentile ranking will be for that year. Looking at current state, where are we at today? For the organization, as Bill stated earlier, looking at our AIP metrics, we did end the year with 4.37, which is the 91st percentile. That does keep us in the top decile ranking, which means that we are performing 91% better than other healthcare organizations, similar and like to JPS. Looking at the tier distribution breakdown, looking at Tier 1, we have 180 groups that make up the 70%. We have 67 groups that make up Tier 2, and then we have 10 groups that we have reduced to the Tier 3, which is excellent work for JPS, our leadership team, and to our team members as well. Action planning readiness is an 88, which continues to show that for us as an organization, our team members continue wanting to action plan with their leadership, with the organization. And this is through the results of them knowing that we as a leadership team, that we take the survey very seriously. That's why we have branded the survey with Share Your Voice, because when they do share their voice, we do action plan to ensure that we are providing them with transparency, with follow-up and feedback to support them to be high engaged team members. Again, looking at the organization domain manager and employee domain, with the organization, we did have negative 0.01 drop, but we are still scoring higher, plus 0.2% being the national healthcare average. We did score higher with the manager domain as well as with the employee domain as well. Next, what we have is trending data. As you can see in looking at the historical data here, we began this journey back in 2013 when we started at the 24th percentile. Today, we are at the 91st percentile, which is a key milestone for JPS, and this is excellent work that we have done throughout the years. Looking at our response rate has always remained high. This truly means that our employees want to have their voice heard, and they know that we take this information very seriously. The orange lines in the data that you see there is basically showing what the response rate is, looking at the national healthcare average, and JPS has always knocked it out the water with the participation rate being at 93 percentile when the national healthcare average is 75%. The readiness score, we have maintained that and stayed steady with that at 88, showing that as an organization, our team members are wanting to action plan with us. They continue to give their feedback as they know that we do take the action planning and putting this into action very seriously. And again, looking at our engagement scores from 2013, we came in at 4.02, just looking at historical data, till today at 4.37, which scored us at the 91st percentile.
Amazing and awesome work.
Yes, I would say this goes to our wonderful CEO, Robert Early, and Mr. Bill Whitman, who is our COO, who have supported us through this journey. Without them, we would not be able to do, and you know, as employees state, it starts at the top, and it started there. The vision was set, and they supported the vision and have maintained that vision as well. So thank you to our CEO and Mr. Bill Whitman for
Can you
this.
repeat that? I couldn't hear.
Of course, yeah.
Can you repeat that? I couldn't hear at all.
Say what?
This is awesome. My question is, I, as an employee of JPS, do I see this same information that you're giving to the board?
Yes,
Yes.
yes,
Okay.
they do.
Okay.
So what occurs with that, we do action plan. We roll the information out to our executive team, to our leadership team. We set deadline and dates to them to action plan to roll out the information to their team members. The expectation and accountability is that for all tiers to action plan. So if you're tier 1, we want you to action plan tier 2 and tier 3. And so the purpose for us asking for you to action plan is so that you do not have a drop with your numbers, but so that we can ensure that all team members do receive the information. So all team members across the organization, if you walk into their departments, they know their score and they brag about it. And when they're tier 1, they're happy about it, they're engaged, they talk about their tier score. So everyone does see the same data that you're seeing today. So I'm sorry, Dorothy.
Did you have another
That's
question?
good.
Okay.
Okay. So looking next at the tier distribution, again, this just provides you with historical data, looking at the tier distribution here, where you truly see the difference, looking back at 2013 when we did start this journey with employee engagement. We had 80 departments that were tier 3. Today, 2018, we only have 10 departments that are tier 3, which is 4% of our workforce, which is excellent, outstanding. I agree.
What PIA has done also that y'all need to be aware of is you take your high-performing teams and you pair them with your low-performing teams to show how you create that cultural change. She's done a good job. Her and the team in HR have combined those efforts, and that's what's made a huge difference.
So if I'm tier 3, is greater than tier 2?
No, so what it is, so looking at your tier distribution, you have your tier 1, your tier 2, and tier 3. What Robert is speaking to is that for anyone that is a tier 3, what we have developed is a curriculum and program for those tier 3 leaders to go through this program. It's just like an Empower program, a LAP program, where we bring them in once a month to sit down and talk about what does engagement mean, how do they improve their communication, and then we assign them a mentor to work with that is in tier 1 distribution, to meet with them, to give them feedback on what has worked well with them scoring high engagement in their departments. So that's the program that we have developed, which has provided the success with the engagement scores.
Okay.
You had it
I'm
reversed.
headed to a
Okay.
spot. So I'm in tier 3. I hate to admit this. And Scott's in tier 1.
You know, all of a sudden this is off, but go ahead. We'll listen.
So you team me with Scott to help me get to that, okay?
And we develop the curriculum for you. We give you recommendations on what is best practice, go out to lunch, go sit in a staff meeting. So we assist and give you that feedback on to help you make successful to become that tier 1 department.
Taking me to lunch, that's, okay, all right.
And they have to pay for it as well.
All the people out there, you chose Scott. You had that whole room.
Bring up. We want to bring up. We don't want anybody to go down.
Yeah.
That brings down the percentile scores.
So reason I ask that is because, as we talked earlier about maintaining that high spirit of morale here at JPS, is that if I made tier 3, let me see, he doesn't have it. I was trying to look at the badge, it's just, maybe if it's something that's,
To recognize
yeah.
what
that-
team you're on,
yeah, that,
what tier.
in other words, or either there's a T-shirt that I made tier 1, or we made tier 1, I mean, just.
We do the recognition for the tier 1, so that there is like a emblem bat that goes to the badge backer that says that they're a tier 1 department. So we do
Yeah,
recognition
okay,
for that.
yeah.
We do the recognition like during leadership connection of the tier 1 leaders. And of course, Robert goes out to the departments, do the pancake breakfast. So there's a
good.
lot that's done
There's a
with that
whole
recognition.
series of things
Yes.
that we do for tier 1s. And let me assure you, this organization knows who's a 1, who's a 2, and who's a 3.
They do, yes.
Problem with the patient looking at it? If they see tier 1 or tier 2
No, because I don't think it registers with many of our patients that they would know that. And it's not flagrant. It's not something that's big and in their face. It's more of an inside baseball deal that you know the organization here. And quite frankly, a lot of our patients, because that percentage is so low of Tier 3, are not going to encounter a lot of Tier 3 folks. Quite frankly, and most of our team that is in direct patient care are 2s and 1s.
Yes. Right. So looking at, next is the engagement score results. We have components here which truly make up that engagement indicator. Again, providing to you the historical data. These are the core questions that result in making up that percentile score. As you can see, looking from 13 to 18, we did go up with, I would like to stay with JPS Health Network if offered a similar job elsewhere. Looking at, I would recommend JPS Health Network as a good place to work. From 13 up until today, we maintain a high score there because that's very important. We want our team members to go out into the community and talk about how they enjoy working at JPS, and JPS is a great place to work. Overall, I am a satisfied score. Looking at 13 to now, we did achieve a higher score from 17 to 18. I'm proud to tell people I work for JPS Health Network. We did a tremendous jump with that too as well and went up 1 point from 17. I would like to be working at JPS Health Network 3 years from now. Again, this is retention. This is the key thing of thinking about how do we re-recruit, how do we have the conversations with our team members to communicate that we value them and that we do want to see them here from 3 years to now. And we did maintain that score from 17 to 18. I would recommend JPS Health Network to family and friends who need care. As you can see, from 13 until 18, we did see a tremendous jump, and we did maintain that score from 17 to 18. So looking at next is just questions of where you see we did maintain our strengths. As you can see, these are in mostly the organization and employee domain and the percent that is favorable. What you see there, looking at the national healthcare average, is basically showing you how we score high versus the national healthcare average. So these next two slides just shows you what are the strengths for JPS and what we have done well with. The last slide, opportunities for improvement. Even though we did score a high at the 91st percentile, of course, there's always room for improvement and things that we want to work on. We did not have any areas for identified improvement, but we did look at the engagement survey and looked at the lowest scoring items to identify action plans and things that we need to work on from an organizational standpoint. Okay. So are there any questions?
I have a question.
Yeah.
The Tier 1, Tier 2, Tier 3.
Mm-hmm.
Can you kind of visually describe what it looked like, how you roll it out, like designation or something, or?
So looking at that, looking at
Is
Tier
that
1.
like more categorized in the group for improvement, or is it something, because I'm a little bit sensitive to having something to separate different group, because I can envision down the road we'll be in litigation for hostile environment.
Well, no, my thing is,
just be
yeah,
cautious.
yeah,
I just
yeah,
wanna
to
be
be
cautious.
cautious of that. But again, we work with Press Ganey, who is our consultant on employee engagement. And so this is work that they do across the country. And of course, they work with other organizations and putting departments in the tier distribution. What it sets apart is showing that as an organization and with these departments, their work and their achievements as, number one, it's not all about leadership, it's about the team too. So when those questions are being asked, we're asking them about their team, the organization, and their department. So there's a series of questions that are on the engagement survey that helps make up that tier distribution. So when you're doing the survey, you want to be able to have the ability for your organization to be proud of that work, because that's heavy lifting that has to be done to be able to reach that percentile score. So with that is that we do have to categorize so that we can be able to have the ability with a leader for them to understand, how well am I doing as a leader? How am I leading this team? How is the team working together? What do we need to do from an organizational standpoint relating to compensation and benefits? Do we have a great learning environment? So that tier distribution is not only set up for the leader, it's set up on all the different domains to help us and support us on what we need to do to continue the great work as an organization.
DT, let me take also a stab at that, in that a hostile work environment can always be a potential. But I think what has happened here is the culture of recognition. We give pins out to people when we watch them do acts of kindness in the hallway. We give them a pin that says seek joy. We give them pins that says they own it. There's a lot of distinction here for the high recognition. Right. And I think the culture here has gone more to that side than a distinguishing punitive. They've distinguished me as an outlier or whatever. So I don't.
No, I'm good with, like tier 1, you have CEO circle or whatever
sure,
it is.
Sure.
I'm more a little bit sensitive to the second or the third tier. If we put a label on them or something.
Yeah, we do not. We do not.
We
do not label them in any way.
They wear a red vest and said, "I didn't do it."
We do not do that.
Oh, good. They're not labeled. Okay, anything else?
Any other questions?
Okay. So next, what I would like to do is provide the results for the 2018 provider engagement results. Of course, the provider employee engagement survey were taken during the same time frame, so that we could be able to package this together to give the feedback to the employees and physicians during the same time frame. So looking at the provider engagement survey, there are 2 core pieces that are identified in this presentation. So with the provider survey, you have what is the engagement and then the alignment. And those are the 2 core pieces that are different compared to the employee engagement survey, because with the employee, you're just looking at the percentile ranking on engagement, but the provider, you have 2 core elements that you're looking at. With the provider survey, again, they do have a domain breakdown, which is their staff, organization, leadership, and department domain as well. Looking next, we have the trending data. Looking from historical data, what we are looking at is from 16 to 18. We did have a slight dip with the percentile ranking. We did have increased participation from 16 to 18 with the participation rate. Alignment, we have improved with the alignment piece, because with alignment, what the story is telling you here is that our physicians look at as being very important for them to be aligned to the organization to ensure that there is a good cultural fit. And then looking at the engagement score from 16 to 17, we did have just a 0.02 slight decline from 3.90 to 3.89. Looking next, of course, we have those core questions that make up the engagement indicator. The next slide also provides what is the alignment indicator, but I wanted to provide you with an example for the physician survey of what this looks like, of what are the questions that truly make up that engagement indicator. They're very similar to the employee engagement. Looking at, I'm proud to tell people I'm affiliated with JPS. Overall, I'm satisfied with working with JPS. I would recommend JPS to other providers, medical staff, as a good place to work and to practice medicine. I would stay with JPS if offered a similar position. I would recommend JPS to family and friends, and if I'm practicing medicine from 3 years from now, I'm confident that I would do the work working from JPS. Next, we have what is the alignment indicator. I'm not going to go through each one of these as well, but as you can see, there are core questions that make up that alignment engagement score as well. Again, alignment is key because, again, you want to ensure that you have physicians that are aligned with the culture, the patient populations, and also the employees to ensure that they feel as though that they are a good fit and that they trust those individuals that they work with each day in the organization. The next slide provides you with the strengths from the physician engagement survey. Again, the same makeup is the domain, the percent favorable, and then the national healthcare average. And then the second page provides you with the strengths as well. Again, a lot of these focus on the actual organization, department, and leadership domain. And next are opportunities for improvement. And of course, this data has been rolled out to the MEC committee to assist them with their action planning for the year. This just provides an overview of what will be some of their core work that they will look at for planning in the next fiscal year to assist them in achieving high levels for physician engagement. Are there any questions?
This is the first time we've received, we didn't get this.
We did not do this last
Okay,
year, and
all
it
right.
costs, and because it is on the AIP, the recommendation was to share it with the board so we can
It's,
keep up
it's a
the
good
work.
report, and I'm hoping that Acclaim takes some pieces and develop something on it, because it's a nice report. Okay,
Okay,
all right.
good.
All right.
Any
Okay.
questions?
Any questions up here? All right, thank you, Pierre.
Okay, thank you.
So now I need to reconvene in closed session. Okay, we have the closed session item. Okay, all right, but we can get some food and come back.
We have lunch for y'all.
We're reconvened in open session at 2:43. There being no further business, we are dismissed. 1:43.
Yes, ma'am.
I'm sorry, reconvene at 1:43.
We didn't lose that hour.
There being no further business, so we are dismissed, okay? All right, thanks.